After more than 50 years of progress, cavities are on the rise among the very young children in the United States. This trend is revealed by a report released by the Centers for Disease Control in April of 2007.
But in some of our children, tooth decay, dental caries, remain epidemic, a problem our Surgeon General brought to our attention 8 years ago, in the year 2000. A recently published study by the CDC found that 28% of our 2 to 5-year-old children have dental caries. This rate has increased over the past 30 years, in spite of the fact that dental caries are totally preventable. This problem is seen nationwide, and Oregon is ranked with the states with the highest rates of affected children with tooth decay.
The changes I saw at Shoreview Dental between the first and second year after we implemented the caries management program were dramatic. Prior to the program, we saw a lot of emergencies, after-hours calls, papoose cases, and there were so many hospital cases that we were booked out 4 to 6 months. We were even seeing repeat hospital cases. In the typical Medicaid office, the phone is ringing off the hook and there are more than enough people to see. That hasn't changed. But after we implemented our caries management program, we noticed that we could see more people in a day. The stress level was lowered, which parents really appreciated. We could minimize phobia with atraumatic care. We saw a reduction in hospital cases, and we saw children go from emergent situations into healthy, stable environment.
Hello, I'm Stephen Duffin. I've been a general dentist for over 25 years. I live and practice in Portland, Oregon. My primary professional objective is to find the cure for caries, or tooth cavities. This video is part of that story, the hope of a future with no more cavities. Many public health studies show that 80% of all cavities are found in only 20% of the population. In 2000, the Surgeon General of the United States released a report on the oral health of Americans. This report is described as a silent epidemic of dental disease in certain high-risk populations. The epidemic is no longer silent. Treating cavities in young children is particularly difficult. Anxieties related to traditional treatment can lead to adult dental phobia. Restorative care for cavities in young children can be expensive, as many of these children must be treated in the hospital, with medical teams and general anesthesia at great societal cost. Caries is the name given to the infection in a tooth that leads to a cavity or a hole in the tooth. This infection can gradually progress until it enters the nerve of the tooth and causes great pain. If left untreated, the infection spreads to the jaws and other parts of the body and can be fatal. It is important that we understand how the epidemiology of caries is changing and take action to prevent the disease from spreading its reach. In early 2006, I opened a new dental practice with a focus on prevention. My practice is made up of Medicaid children, patients with a variety of developmental and acquired disabilities, and seniors with dementia. These populations are the same groups with the highest rates of dental disease. I set up this scenario so that I would have lots of opportunities to see and treat dental disease. My intention was to study the disease in this population and evaluate various approaches to disease prevention and health promotion. Preventing a disease is always preferable to treating its symptoms. Dental cavities are an example of a disease that is 100% preventable. W.D. Miller was an American dentist and microbiologist working in Berlin in the 1880s. Miller proved that cavities are caused by bacterial infections. He also studied various treatments to arrest the progress of caries. He demonstrated that silver nitrate was effective in arresting the growth of cavities. His work was carried on by G.B. Black, the founder of the modern dental profession. Writing in 1906, Black advocated the use of silver nitrate to arrest cavities in young children. He was also a leader in the discovery of the value of natural fluorides in preventing dental disease. Weston Price was a dentist practicing in Cincinnati, Ohio in the 1920s. Dr. Price noticed that there were large differences in the number of cavities among different groups of his patients. He wanted to understand why this was. He had heard that people living in remote areas of the world and eating native diets had lower rates of cavities. Dr. Price set out on a number of expeditions, Indiana Jones style, to isolated areas of the world: Africa, South America, Alaska, Australia, South Pacific Islands, and remote populations in regions of Europe. Dr. Price documented in enormous detail the relationship between cavities and the local diet of populations and the degree to which sugar in Western food products had reached these populations. His research shows conclusively that cavities are a phenomenon of the high sugar content in Western diets. In many remote locations, he found that less than 0.5% of the population had any cavities at all. Interestingly, there were no toothbrushes and no dentists in many of these areas. As he studied populations more closely associated with Western diets, the rates of cavities shot up dramatically. Dr. Price's work showed without any doubt that cavities are a phenomenon of poor dietary behaviors. Upon returning to Cincinnati, he instituted a number of local programs to study the effect of improving diets and eliminating simple sugars for children living in institutional settings. These purely dietary interventions resulted in the arrest of caries and progress in the decline in new disease. Many studies completed during the last 25 years also show a high relationship between sugar intake and the development of cavities. Multiple different species of bacteria living on the tooth surface use these simple dietary sugars to make acid, which dissolves tooth enamel, infects the tooth structures, and also kills the healthy natural bacteria in the mouth. Recently, I had the opportunity to see two brothers, 3 and 5 years old, in my office together with their mother. This was their first visit to the dentist. During the examination of the 3-year-old, I was pleased to discover no cavities and a very clean and healthy mouth. When I started to examine the 5-year-old brother, I noticed with the clear telltale signs that cavities had started forming in his back teeth when he was 2 or 3 years old, and then the cavities had completely arrested. This was a clue to me that something interesting had happened in the family about 2 years previously. When I explained this to the boy's mother, she responded, "That's right. I was diagnosed about 2.5 years ago with diabetes, and I had to get rid of all the sugar products in my house. Most likely this diagnosis for the mother and the subsequent dietary changes stopped the progress of cavities in her 5-year-old and prevented cavities from ever getting started in the 3-year-old. In my practice, I gleaned all of the information I could find from the early clinicians and researchers such as W.D. Miller, G.B. Black, and Weston Price. I then went on to look at the recent literature on dental caries. The current work of Philip Marsh and John Featherstone clearly demonstrate that dental infections and cavities are the result of imbalances in the natural ecology of the mouth. This imbalance is due largely to the influence of simple sugars in the diet and the production of acids by bacteria. It also was clear to me that placing fillings into teeth with cavities does not influence the infection that caused the cavity. People continue to get cavities or need fillings replaced over time.
Dentistry is treating the symptoms of a disease. Dental disease, both dental caries and periodontal disease, is an infectious process. It's caused by bacteria. And we have gone about restoring the damage that the bacteria has done. We go to the mouth like carpenters to a burning house, restoring the bedroom and the bathroom, remodeling the kitchen while the house is still on fire. Wouldn't it be wonderful if we figured out a way to bring out the firemen first, stop the disease process, and then spend the bulk of our time restoring the damage that's been done? At the present time, I feel that we're spending about 90% of our time restoring the symptoms of the disease, restoring those things that are caused by the bacteria, and about 10% trying to educate people on how to prevent it. Wouldn't it be wonderful if we can turn it around and spend 90% of our time preventing the disease, and we will only have to spend 10% of our time correcting the mistakes, the problems that the infectious process has caused.
This is a photo of a young child who is being treated in the hospital for massive dental disease in most of her teeth. It is clear upon careful inspection of the photograph that this is a repeat hospital case. The first attempt to treat the disease was a failure, most likely because the high sugar diet did not change and attempts at oral hygiene were inadequate.
What are some of the factors contributing to this problem? First of all, Oregon provides only municipal water fluoridation for about 25% of the state's residents. Secondly, our children are eating more processed foods and snacks at home and in school, and most of these convenience foods contain high levels of sugar. Many of the popular drinks that children consume also contain high levels of sugar, and sugar causes tooth decay. Parents are also failing to have many of their children brush their teeth twice a day, and very few children are being referred to a dentist by 1 year of age, even though this is recommended by both the American Academy of Pediatrics and the American Academy of Pediatric Dentists.
Once it occurred to me that cavities are essentially a disease of diet and behavior, I knew I had my work cut out because people do not like to change. I'd been telling patients to quit drinking soda and brush and floss for years with little result. So I decided to study the literature on behavior change. A great body of information exists on this subject as it has been applied to topics such as smoking cessation. Health belief models describe how patients interpret the cause of disease and their role in managing their health and wellness. Motivational interviewing and its application to dentistry holds great promise for improving the effectiveness of our prevention education efforts. Understanding the stages of change and the patient's readiness to move forward with healthy behavior choices has been well described by Philip Weinstein and Peter Milgram at the University of Washington School of Dentistry.
Today he told his doctor he don't eat candies because dentist said no. What does the doctor ask for you today?
You want a lollipop? And say no, I know that eat candy. I'll say a sugar-free one.
Okay.
As I began to teach using questions rather than using statements and scientific information, I began to see messages sinking in and people taking responsibility for their health and wellness. This patient was able to arrest all of the active dental decay in his mouth by simply improving his oral hygiene and changing his high-sugar diet. Healthcare in the United States has evolved around the central theme of disease treatments. We have spent vast resources on the development of technologies and therapies to address the symptoms of disease. The extreme smile makeover has captured the attention of many Americans, and we have forgotten about the biological basis of the disease, so well understood 100 years ago. A shift in the focus from expensive treatments of symptoms and toward prevention and wellness promotion will be the foundation for correcting the problems in our healthcare systems. Dental disease is an excellent place to start as we know how to prevent the disease. Opportunities exist for collaboration between dental, medical, public health, and education professionals in addressing the challenge of increasing cavities in young children. Using existing economic resources, we can spread preventive interventions to a larger population. Our current healthcare financing systems reward disease care and do little to promote individual responsibility for behavioral aspects of this complex biosocial disease. This situation must be turned completely upside down, so that the benefits of wellness are shared by patients, healthcare providers, and the institutions that finance healthcare services.
I've been in dentistry, in the field of dentistry for 40 years. I started out as a dental assistant for my dad, and then I was a dental hygienist in the 60s. At that time, the general population believed that, why take care of baby teeth? You're just going to lose them anyway. Why take care of adult teeth? Because you're going to end up in dentures anyway. But through the 60s, there were three major changes. One was water fluoridation. Another one was the advent of dental insurance. The third one is the proliferation of dental hygiene profession. And our job was to teach patients how to take care of their teeth. In the last 40 years, there's been a huge improvement in oral health in the U.S. population. When I retired a number of years ago, I thought our job was done. I felt so good that we had actually made a big improvement in oral health in this country. And then I started to do oral screenings for Head Start because I had the time to do it. And I was shocked. I had no idea that our little kids had such bad teeth. So I started to see what I could do about that. And one of the biggest things I discovered is that in the low-income population, and especially the immigrant population, they have the same beliefs that we had in the 60s. Why take care of baby teeth? You're just going to lose them anyway. And there isn't anything you can do about cavities in the permanent teeth. And then I realized that in our profession, we are not telling people the things that they have to hear. We think that people are going to do the things we want them to do because we told them to do it. What we're not telling them is exactly what the decay process is and how they can prevent decay in their own mouths. And one of the things is that I discovered that when we talk about cavities to people, they don't know that they're actually holes. So what I've been doing in these number of years is trying to go to populations that don't have the advantage of going to a dentist on a regular basis and just training them about what causes tooth decay and what they can do to prevent it. And one of the most effective things I've ever done is develop sugar bags. And these are bags that will actually tell people how much sugar is in the food and the beverages that they consume. The other thing, especially when we talk to little kids, boy, we show gummy bears because kids love gummy bears, and we show them how much sugar is in gummy bears. So they can really understand that there's a correlation between the cavities they have in their mouth and the sugar that they're consuming. Head Start has been a wonderful place to disseminate education because they have parent meetings. We also talk to the kids. But what's really happened, a change in Head Start has been that I read an article that said that if we can put fluoride varnish on kids, on little kids, 3 times a year, we can reduce their decay by 40%. We got a law passed in Oregon so that the health assistants with training can actually apply the varnish. What we do now is that when we do our oral screenings for the Head Start kids, I'll do the screenings and the Head Start people will put the varnish on. And this has been great.
Dental caries, or cavities, as most of us call them, are 100% preventable. It's great news. The dental community alone cannot solve this epidemic problem. Strong partnerships with our medical colleagues who can help communicate the importance of oral health are a critical starting point. Many parents are not aware of the benefits of good oral health. As a result, many of these children will never see a dentist before it's too late. Most very young children do come in for regular checkups with their medical providers, though. The Well Child Check presents a wonderful opportunity for medical providers to do a brief oral exam, provide a preventive fluoride varnish, educate parents on the importance of oral health and the importance of baby teeth, as well as referring the parent to a dentist for further evaluation and care. Working together, we can all come one step closer to having Oregon's children cavity-free.
Almost half of the U.S. population does not have access to routine dental care. Most dental disease is preventable with early intervention. Dental disease does not just affect the mouth, but also has many adverse effects on overall health. Dental hygienists can bring preventive dental services directly to patients in community-based settings, which include daycare centers, schools, public health clinics, hospitals, and nursing homes. It is critical that patients in these settings receive dental services to prevent the negative health consequences which result from untreated dental disease. Dental hygienists can improve health outcomes for patients in these settings by increasing their access to oral health education and prevention services.
Several states are showing us that dental caries can be prevented, and they are doing so by enlisting physicians and nurses in this effort. A good example can be seen in North Carolina, where primary care providers are performing dental examinations, applying fluoride varnish to the teeth as soon as they erupt, and by providing nutritional counseling and education to the child's parents during their regularly scheduled well child care appointments. These practices are paying off. The number and the severity of dental caries in North Carolina's children is decreasing. Working together, parents, teachers, and medical and dental professionals can spread the message of prevention to spare our children from the ravages of tooth decay. Dental caries are preventable. By working together, we can all help our children grow with no more cavities.
A very important aspect of developing my prevention-focused practice was to create an economic environment that supported this philosophy. It must become a financial incentive to have healthy patients in the practice. In order to support this practice model, I established a membership assignment and prepaid economic foundation for the business.
When we first started this practice, I was assisting in the back office with Dr. Duffin. We were seeing a lot of kids with a lot of decay. We would dread those mornings when we would come in and see papoose on the schedule, and we knew we had to strap down these kids while they're kicking and screaming, and their parents had to help us by holding their head down as we worked as fast as we could to get their treatment done. It wasn't a pleasant experience for the child, the parent, or us. It was extremely stressful and awful. When Dr. Duffin started the Caries Arrest program, we started seeing a lot of changes in our office, a lot for the better. We had a lot less papoose treatments, a lot less hospital cases, and a lot more happy kids. We started seeing them for short visits, at least once a month, and at that time we were able to talk with the parent about lowering the disease process with proper brushing, less sugar, and coming in for regular fluoride visits. This left the kids a lot happier, and the atmosphere in our office changed dramatically.
We are spending more time on diet counseling and oral hygiene instruction. Behavior change is crucial, and this message is being reinforced at each visit.
Dr. Duffin's philosophy of care and his Carrie's management program made me look things at a different perspective. We do non-invasive, atraumatic procedures by using the Carrie's management program. I've seen significantly fewer emergency visits, fewer children being papoosed, and less use of drugs to alleviate their stress before coming to the dentist, and no use of nitrous oxide in children. Less hospital cases where we would put the children under general anesthesia. It's so exciting because some of our children that come in to our office, they can't wait to open their mouth for us to look, and they leave with a smile. Painless visit.
The prevention practice should be the foundation for all traditional restorative procedures. Addressing the infection that led to the original problem enhances the prognosis for success and the longevity of any dental treatment. Dental restorations do not cure infections. Modern prevention-focused clinicians will understand when the oral biofilms in their patients are pathogenic and how to assist patients to move their oral health toward balanced, healthy conditions. Today we have a variety of products and treatments that are effective in the prevention, arrest, and treatment of cavities. These products include antimicrobials, fluoride varnish, fluoride-releasing sealants, and filling materials. We also know that the caries infection is a very complex disease, potentially involving hundreds of species of bacteria, and many environmental factors such as diet, oral hygiene practices. Many people fear going to the dentist. This attitude was either created by an unpleasant experience having a cavity treated or hearing about a painful experience from another person. Properly managing fear and anxiety, especially in children, is essential to successfully controlling the disease.
Seems to enjoy coming in. Before he was a little uneasy about coming until he found out that it wasn't going to hurt him.
Too many children are trapped in a vicious cycle of disease, pain, and unpleasant experience having a tooth removed. The prevention practice breaks this cycle by promoting atraumatic and minimally invasive treatments which are focused on treating the infection that causes cavities. Once I discovered that there are effective treatments to arrest caries, the experience that my patients and I are having in the office has improved dramatically. Children that did not want to open their mouths and cowered at the prospect of going to the dentist now are perfectly happy to jump up into the dental chair and open their mouths wide to allow us to place medicine on their teeth.
We started the Tooth Fairy program where the children would bring back to the office the primary teeth that they lost that had been treated in the office, and doctor would buy back the teeth for $5. This way we could further our research and the effectiveness of our caries management program.
My caries management and arrest program includes many return visits to the office so that I can reapply prevention treatments to affected teeth. At each visit, I also have the opportunity to discuss diet, evaluate plaque levels, oral hygiene practices, and to document levels of cooperation.
With each visit, the children come in for their caries management visits. They become more comfortable to the dental office. We are able to teach and educate parents about the role of sugar and diet, and most important, education and reinforcement of prevention. Each visit is a happy visit, easy and positive experience for both the parent and child. In the past year or so, we've been doing so much different types of research using different types of antimicrobial agents that can kill infections and cavities, recording each antimicrobial and testing it over and over again. We're on the verge to something very exciting that will have a significant impact on dentistry.
I've received inspiration from the father of the dental prevention movement in America, Robert Barkley, the author of the classic book, Successful Prevention Dental Practices. I have also received inspiration from Portland pediatric dentist Alan Pike, author of the No Fear Dental Practice. I try to evaluate risk factors during treatment so as to manage toward an endpoint of no active disease in a completely restored dentition. We begin a dialogue about the role of diet and oral hygiene in controlling the disease. We treat obvious infections with antibiotics and extractions if necessary. I set up a schedule of appointments to apply caries arrest agents on all active cavities, such as 10% silver nitrate or silver fluoride, with a microbrush. I immediately follow with fluoride varnish. Repeat at 2, 4, 8, and 12 weeks and reassess the disease activity during this process. Reinforce dietary counseling using motivational technique. Going forward, I increase or decrease the schedule of interventions based on disease activity. A recent review article by Rosenblatt and colleagues at Harvard and the Forsyth Institute labeled silver fluoride a silver bullet for cavities. Much more exciting research on caries arrest is on the horizon. Once all signs of active disease are absent, I consider restorations for function and aesthetics. In many cases, arrested cavities in primary teeth do not require any additional treatments. I explained to parents that the dark stain on the tooth that represents arrested and inactive caries is like a scar. The tooth had an infection, we put medicine on the tooth until the infection was gone, and now there is a little scar there to remind us what could happen in the future if we do not change our diet and oral hygiene. When one member of a family group enters our prevention program, we must consider the entire family as our patient. People living in close contact have similar microorganisms in their mouths. Children share toys, utensils, and saliva transfers bacteria from person to person. CAMBRA, or Caries Management by Risk Assessment, is a movement that was founded 10 years ago by Kim Cooch, John Featherstone, Doug Young, and others interested in raising awareness in the profession about the importance of treating the disease and not just doing fillings to treat symptoms. This is another philosophy of practice that guides us through the steps of prevention and restoration. CAMBRA focuses our attention to the risk factors for disease and the current activity of the pathologic conditions in the patient's life. Disease occurs when the balance of protective and destructive factors come out of balance. 40 years ago, Robert Barkley was recommending the use of phase contrast microscopes in the office to educate patients about the role of bacterial plaque in dental disease. A slide with a fresh plaque sample has many motile organisms that will get the attention of anyone. I often ask the entire family group to have a look in the microscope when treating one child. The phase contrast microscope is by far the most powerful piece of technology that I use in my office to promote prevention.
Can I have a toothbrush?
The Carrie screen meter is a new technology from Oral Biotech that is used to measure the acid-producing potential of bacteria living on the surface of the patient's teeth. It is a useful tool for doing real-time in-office risk assessments and to measure the progress to a healthy point. Diagnodent from Cavo Dental Corporation is a laser-based instrument that is able to detect cavities at a much earlier stage, allowing for smaller, more conservative fillings. Plaque Check from GC America is a 5-minute in-office test that measures the actual acid produced by the dental plaque bacteria in response to an exposure to sucrose. This is another powerful teaching tool and allows the clinician to measure progress from disease states to healthy conditions. While we have seen very positive results using a variety of treatment strategies, there remains much to be discovered. We need to reprioritize what is emphasized so that there is more focus on education and dietary counseling rather than just traditional restorative services. The economics of healthcare needs to support this paradigm shift. Value must be placed behind prevention interventions rather than only surgical procedures. If we focus our efforts on disease prevention, children today can grow up with no more cavities.